Yes,
So
ma'am.
I welcome one and all for this meeting today, which is on pelvic floor rehabilitation. So, which is very important for us, for all of us to know about. And we have eminent speakers and eminent chairpersons with us today. So, as usual, we shall begin the program by a small invocation. So, I shall sing a small invocation today. Arun has not responded. So,
Ma'am, I'm here, ma'am. I'm ready. You can.
okay,
You can, ma'am. You can.
okay, okay. Thank you. So, seeking the blessings of Lord Vinayaka, we shall go ahead. I'll be singing a small stuti. महागणपतिं मनस स्मरामि महागणपतिं मनस स्मरामि महागणपतिं मनस स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिम् महादेवसुतं महादेवसुतं गुरुगुहनुतं नादकोटि प्रकाशं कान्तं महाकाव्यनाटकादिप्रियम् मूषिकवाहनमोदकप्रियं महाकाव्यनाटकादिप्रियं मूषिकवाहनमोदकप्रियं महागणपतिम् Thank you.
Thank you. Very nice, Aarti. Very nice.
Thank you, ma'am. Thank you. So over to, I would like to introduce Vijay sir, who will be then introducing our, and then he will take over the proceedings. Vijay sir requires no introduction now. He is the head of the department, excellent urogynecologist, and he is the chairperson for Urogynec Committee Kasuga.
Okay.
Over to you, sir.
Thank you. Good evening to all. As usual, we are having this month the webinar pertaining to the urogynecology and midlife. Today, we have a very interesting topics. Two topics. One is the pelvic floor rehabilitation, which will be spoken by Dr. Uma Venkateswara, who is an authority on pelvic floor rehabilitation. So, and the second topic is the neuromodulation and its significance in urogynecology will be spoken by Dr. Kiran, who is a dedicated urogynecologist and active person. So I thank our President Durgadas sir for gracing the occasion. I also thank Secretary Dr. Shobha Gudi ma'am and Treasurer Dr. Bembalgi madam. Due to for some unavoidable reasons, they are not present for this webinar. I also welcome all the delegates. I am seeing all the important delegates for this evening. I'm sure this webinar will be quite useful for all the practicing urogynecologists as well as gynecologists. And I request our President Durgadas sir to say a few words. Over to you, sir.
Good evening, our family of Kasoga. At the outset, Dr. Arati, one of the melodious invocation we have sung. Thank you. Really,
Thank
Ganapati
you.
is going to bless us.
Thank you, sir.
As usual, Dr. Vijay Kumar and his team, who is heading the urogynecology team, you have chosen very unique topic. This is not spoken anywhere. We can hear this subject in any of the conferences or the webinars. I really should compliment you for selecting the topic as well as selecting the speakers, the very eminent speakers like Dr. Uma Maheshwari, Next is our own Dr. Kiran. To tell you frankly, he's a genius of the whatever topic you give with respect to urogynecology. It's a pleasure to listen to his talk. And today's chairpersons, Dr. Meena Mahalingam. I can I can understand the commitment. Though you are in Bhopal, you have logged on to our program. Really, I congratulate you for logging in today. As well as I welcome Dr. Kavita Barmal and our own Dr. Indukala and Dr. Jyoti GS. With these few words, once again, best of luck, Dr. Vijay Kumar, for the whole evening and for giving such a fantastic program. All the best.
Thank you, sir.
Thank you, sir. So we would like to start the first session on pelvic floor rehabilitation, and we have Dr. Meena Mahalingam as our chairperson. Arun, can you share the CV, please? Dr. Meena Mahalingam, she is Associate Professor in Obstetrics and Gynecology, Chengalguru Medical College, Secretary OGSSI, Co-Chair Urogynec Committee, Member Urogynec Committee FOXY. And she has special training in urogynecology, microsurgery and endoscopy. She is an instructor for basic newborn care and resuscitation program. Total, she has 23 years of experience, master trainer EMONC, and she has various memberships to her and she also takes care of adolescent health camp, blood bank camp, district instructor in IAP, received scholarship from IUGA. Over to Meena ma'am to introduce our speaker.
Is Dr. Kavita madam
Dr.
there?
Kavita ma'am. I think Dr. Kavita ma'am has not joined. Alva sir?
But you introduce madam, Dr. Aarti. Kindly introduce Kavita madam.
Yeah. Dr. Kavita Banwal is one more chairperson for the session. She is a fertility specialist, Indra IVF, Samarpan Hospital, Mangar. She is a chairperson, Urogynec and Pelvic Floor Repair Committee, FOXY 24 to 27. Associate Professor, Lord Buddha Koshi Medical College, Sahasra. Recipient of Padma Bhushan Kamlabai Hospital Award. Received the Dhira Award in 2023. Member YTP Committee, FOXY 21 to 23. Organizing Secretary of 9th AOG SBG in 2022. She has credit of bringing DK Tank trophy for the society in 22. Member of RCOG, presented paper in RCOG 2023, edited and wrote many books, done more than 8,000 laparoscopic surgeries, great environmentalist, member of Lions and various other bodies, presented papers in many national and international conferences. So over to Meena ma'am to introduce our speaker today, Dr. Uma Maheshwari Venkatesha. Meena ma'am?
Yeah. So thank you for the wonderful opportunity. Karnataka Society of Urogynecology, Dr. Durga sir, Dr. Vijay sir, and Dr. Aarti, and the entire team. All the best. So it gives immense privilege to introduce Dr. Uma Maheshwari Venkatesa, who is an American board certified physiotherapist currently practicing in Chennai, India, as a head of pelvic floor physiotherapy unit in Jogodan. She graduated from Madras Medical College in 1987 and practicing ever since 1988. She has presented various papers in national and international conferences, conducted workshops for training physiotherapists on pelvic floor dysfunction. She's taken individual efforts to create awareness about the pelvic floor health among school, college children, employees in IT companies, and women forum. She has received the Best Physiotherapy Award from State and National Indian Association of Physiotherapists Conference for her years of service and study on interferential therapy for incontinence. So we welcome you, ma'am, and we ask you to start the session on pelvic floor rehabilitation. Over to you, ma'am. Thank you.
Thank you so much for the introduction, Dr. Meena Mahalingam. Respected Dr. Vijay Kumar and Dr. Arti, and all the senior doctors, thank you so much for giving me an opportunity to talk in this forum. I'm going to share my slide. Can you see my slide?
Yes, ma'am.
Oh. So today, my topic is on pelvic floor rehabilitation. As Dr. introduced, I'm a physical physiotherapist and specialized in pelvic floor physiotherapy. As you all know, urinary incontinence, the prevalence is so high, 64% in women above 60 and 40% in postpartum women. And 90% of the women never discuss about the incontinence. And in conventional physiotherapy, in conventional pelvic floor physiotherapy, that itself is a new field in most of the places. And we use electrical stimulations and myofascial release and Thiel massage and electrical stimulation, interferential therapy, so many types. But we, in our institution, we use the electromyographic biofeedback technique, which is very important for objective assessment. It is very difficult to isolate the pelvic floor muscle contractions when the urogynecologist or a urologist or a obstetric and gynecologist, when they are assessing, it differs from one healthcare person to other. Inter-rated, intra-rated variability is there. But using the device, EMG biofeedback innovative device, advanced digital therapy, we can have a proper validation. And without any proper assessment, it is very difficult to form a goal. So a structured evaluation, comprehensive evaluation is very, very important. And then in conventional, it is non-quantifiable, but using this digital therapy, we can quantify the assessment, treatment, and also the discharge process. And here needs very little supervision because the patient is able to see her own muscle contractions in the form of the graph. And then adherence is a big problem. Whatever we give home program, whatever instructions we give to the patients, they don't adhere to the exercises. So here we can give the device to the home and ask them to practice on a daily basis. So it is very non-invasive, portable, real-time, and tele sessions also we can conduct, and there is active engagement of the patient, and there is objective assessment. So EMG biofeedback, jogotherapy, innovative, what we use is based on the neuroplasticity training. So we are giving the training using the device for the brain muscle interaction. There is a lot of learning involved, which restores the neuroplasticity. And it is also Phyton exempted, FDA approved, and CEDESCO approved. And it can be used, and we are using for clinical studies and publication and all. And we have a connection with Mayo Clinic. So when it comes to pelvic floor dysfunction, as you can see, this is a healthy pelvic floor where there is a normal strength, proper strength without any incontinence or voiding issues. There is a normal tone in the pelvic floor muscles. Here there is a weak pelvic floor muscles. The tone of the muscle is very less. There is urinary leakage and fecal incontinence, organ prolapse. All those things are happening when the muscles become very weak. Another condition is the tight pelvic floor muscles, increased tone. Because of that, the patient is having voiding dysfunction, chronic pelvic pain, dyspareunia, all those women suffer. So when it comes to pelvic floor rehabilitation, we classify into two basic categories: weak pelvic floor muscles or decreased tone, where there is incontinence, organ prolapse, bowel incontinence, and then surgical conditions where the tone is less. Next one is tight pelvic floor muscles or increased tone. There is dysfunctional voiding or voiding dysfunction, vaginismus condition, chronic constipation, anismus, dyssynergic defecation, and chronic pelvic pain. So these are the conditions we treat in pelvic floor unit: obstetric gynecological condition, antenatal, postnatal, stress, urge, mixed incontinence, vaginismus conditions, organ prolapse, valve prolapse, voiding dysfunctions, and also before and after pelvic surgeries like corporophy, transvaginal taping, sacrocolpoplexy, all those things. So we also treat male patients with pelvic floor issues, and also children with pelvic floor issues apart from women. So the international guidelines, American Urological Associations, American Urogynecological Association, European Association, all the association endorse biofeedback. And then, as you know, the important roles the pelvic floor muscles plays is organ support, sexual function, sphincteric function, core support, and then circulation. So there are evidence-based international conferences and journals where we have published in RCOG World Congress in 2024 in Oman, and we presented our work in American Urogynecological Association on voiding dysfunction and International Urogynecological Association on case studies on spina bifida with incontinence and also voiding dysfunction. Recently, we published in Digestive Disease Week conference in US in San Diego on a group of dyssynergic defecation patient and also fecal incontinence patient. So we have also published in the field of chronic low back pain and gastroenterology, hepatology, endoscopic practice on dyssynergic defecation, how pelvic floor physiotherapy can help in Indian study. So when it comes to precision muscle training, through 10 sessions, we have a comprehensive assessment. We spend about 1.5 hours in understanding the patient's problem. We assess the musculoskeletal part, if the patient is having any back pain or anything, and also pelvic floor assessment, and then EMG biofeedback assessment. And then we have a structured program for our patients, 10 weeks, once a week for 10 weeks. And we send the assessment report, midterm report, and also discharge summary for the referral physicians. So I just wanted to show a small video. 1 minute. Can you hear? Can you hear the video?
Not able to. We are not able to. You have to share, madam. Go to the share. Yeah.
1 minute. Now can you see?
And urogynecology
Can you hear?
at Fortis Hospitals,
Yes,
Bangalore. Today, I'm here to talk about JOGO, which is the newest tool in our armamentarium of treatment options we can offer to our patients. Now, what JOGO is it is a kind of biofeedback induced physiotherapy. So where we use it as clinicians is that when we have a patient who has a lot of issues regarding incontinence, where there is urine leakage, or when they have voiding dysfunction, wherein they are not able to empty the bladder properly, or even in sexual dysfunction. So all these are heavily dependent on the neural pathways which are present. And when we commonly tell physiotherapy to the patient, because pelvic floor is such a muscle which is very difficult to identify by the patient themselves because of where it is located and how it acts. first of all, for them to identify the muscle and then to act on it and to stick on to the kind of physio which is recommended to them just becomes more and more difficult. So here what we do is that what the physiotherapist does is that they assess what exactly is the pelvic floor dysfunction, because there are various levels of dysfunction which can happen on the pelvic floor level. So once it is assessed, a treatment protocol is made for what you require. So and then they introduce these they apply these surface electrodes. So earlier biofeedback is done by the use of vaginal cones, where we introduce something into the vagina, and that is an invasive mode which not every patient is comfortable with, especially when the issue is with, say, sexual dysfunction. So here it's a surface electrode, and this sends out signals which are called the EMG or the electromyogram. So when you see what muscle you're acting at, what strength you're acting at, and also when you hear the feedback of the muscle, then it reinforces in your brain, and it works on the principle of neuroplasticity, where the new neural pathways are formed and reinforced, which help in effectively targeting the muscles which need to act and the nerve pathways which need to act to ensure that you have a proper control over your urination and you don't leak, and you have a proper emptying of the bladder. Especially in our scenario, where I would recommend it to my patients is when there is a complex issue, which, especially in voiding dysfunctions is where we use it more often, and in early cases of incontinence, apart from sexual dysfunction also. And over time, we have seen that when patients adhere to the therapy, especially the recommended 8 to 12 weeks of therapy, because that's how long it takes, like in any other muscle of your body, that's how long it takes to form and enforce the neural pathway. So once that initial 3 months is done, you're able to continue and practice this lifelong. Thank you.
So in pelvic floor therapy, we have a detailed, structured, comprehensive evaluation. First, we do the subjective assessment with getting the history and also outcome measures and stop test and bladder diary, all those things, time taken to urination. And then we do the objective assessment of the joints, vertebral joints, soft tissue tightness, neurological assessment, pelvic floor muscle strength assessment using EMG biofeedback, digital therapy, and also transvaginal and transrectal examination using the perfect score and muscle assessment, modified assessment, and trigger points. We understand the overall pelvic floor muscle status and then joint capabilities and classify them into weak pelvic floor muscle or tight pelvic floor muscle or combination of both, and then formulate a structured plan of care. So when it is a tight pelvic floor muscles, we do downward training or pelvic floor relaxation therapy or reverse Kegel. When it is weak pelvic floor muscles, low tone, we do the upward training or pelvic floor muscle strengthening training in static and dynamic posture. So by using this learning technique, where the patient is able to learn with the help of the electrodes, the muscles are recruited, and then the afferent impulses are carried to the brain, and then interpretation is taking place in frontoparietal cortex, and then efferent impulses are coming down, and then there is a long loop mechanism. The patient is learning how to do a normal contractions by looking at the graph. So I just wanted to show how it works. These are the components of the device. Electrodes and probes and the sensors are connected to the tab through Bluetooth wireless mechanism. It's very portable. This lady is having a wrist drop, and we have connected to extensors of the wrist muscles. And when she is doing the wrist extension, you can see the bar graph going up. So we can set the goal and increase the strength of the muscles. Similarly, when it comes to pelvic floor, this lady is an incontinence patient. We have put the vaginal probe, the blue graph, and then the red is the transverse abdominis. So we are teaching how to recruit the isolated pelvic floor muscles, and then through the process of elimination. She should not contract her abdominal muscles. She should work only on the pelvic floor muscles. She's learning and trying to recruit and improve her pelvic floor muscle strength. So it's precision, measurable, non-invasive, real-time feedback and 1,000 times magnified. It is much better than the conventional because here there is active participation of the patient and then objective assessment is there. Isolated muscle relaxation and contraction, we can track the progress through validation. So patient is motivated every week. The patient is coming and looking for the report and then objective assessment. How she is making progress week by week is validated. So I just wanted to present a case study. It's a 76-year-old female with overactive bladder treated with EMG biofeedback. The patient presented with complaints of unable to control the urge, increased frequency of urine at night time in every 1 to 2 hours, overactive bladder, known case of hypertension, hyperlipidemia, hypothyroidism, 15 years with medications, and also vertigo problem. So we did a SOAP format examination, and then this patient had no complication in the delivery, and then she's about got her menopause at the age of 42 and using the estrogen, and also daytime frequency is 9 to 10, nighttime is 4 to 5 times. We use outcome measures like ICIQ, International Continence International Questionnaire, for a short form for urinary incontinence. She scored 7/21 and Cosian scale 2/10. These are the outcome measures we use. And then we also did the internal examination where to understand the pelvic floor muscle strength. She was not using isolated muscle work. She was using abdomen and breath holding. And also we grade according to the modified Oxford scale. She was 2/5. And we use perfect score, power 1/5, endurance 2 seconds, repetitions 3, fast contractions 2. And every contractions we time it. So this is the way we keep the surface electrodes on either side of the vagina to recruit the bulbocavernosus muscles. And then once the muscle is recruited, the impulses are carried and displayed in the screen in the form of graph. So as you can see, in the crook-lying position, the muscles are recording the relaxation. The patient is so agitated, unable to relax. And then type 1 fibers, slow contractions, we are asking the patient to do. The patient has no clue. She's not aware about the pelvic floor contractions. Then we are asking her to do the quick contractions, type 2 fibers, and she's able to do mild 4 quick contractions. So the therapy's objective is to increase the pelvic floor tone and then make the patient understand about the importance of pelvic floor contractions, bladder retraining using bladder diary, home program, pelvic floor education, and lifestyle modifications. So we did 10 sessions for her, and also we advised her not to use bladder irritants like coffee, tea, and orange juice, and citrus products. And then bladder diary, daytime frequency was 12 times and nighttime 5 times, urgency not able to control. And then this is a week by week, we have a structured pelvic floor exercise program using the Jogo EMG biofeedback connected to their body, where we have exercises, gravity assisted, gravity eliminated, gravity resisted, step by step progressing from static posture to the dynamic posture and using the ball and TheraBand as a resistance. So the patient is progressing week by week, and she's also practicing at home for the home exercise program. So this is the outcome measures before and after. It was before 2/10, then it came down to 1/10. ICAQ 7/21 came down to 1. Daytime frequency 12 times came down to 7. Nighttime 5 times came down to 3. Before she was not able to control, now able to control till she reaches the washroom. So these are the graphs where x-axis is calibrated in time. 30 seconds, each square is 3 seconds, and y-axis is calibrated in muscle potential, how the muscles are recruited in the form of millivolts seconds. So before starting, she was unable to relax. Then on the 10th session, she was able to relax much better. And then first, she was unable to do the slow contractions. But in our 10th session, she was able to recruit very well and then can hold for 5 seconds. She was able to recruit for 21 to 42 millivolts second. Quick contraction, initially she was able to do only 4. Now she is able to do 10. And also the amplitude increased to 28 millivolts from 23 to 28. So there was a significant symptom reduction, able to control the urge till she reaches the washroom. Frequency reduced from 12 to 7 and then 5 to 3 in night times. And quality of life has improved. So there is, we asked her to continue the program, and we have a 3-monthly and 6-monthly follow-up to check whether the neuroplasticity is maintained. So she is able to maintain the improvement. Second case study is on lower urinary tract syndrome with interstitial cystitis, bladder pain syndrome, referred by a urologist after 15 to 20 installation and cystoscopy. A 40-year-old female came with complaints of having bladder pain for past 4 years, along with lower abdomen pain, pain on moderate filling. Chief complaint, urine urgency, urine frequency more than 15 times a day. Difficulty while initiating the urine, low back pain. She also have disc problem in the cervical and lumbar, epilepsy. So she was on all these medications for a bladder problem and also epilepsy problem and pain problem, back pain, all those put together. And then a pelvic floor evaluation was done with structured examination. Tight pelvic floor muscle was observed, increased tone in left deep pelvic floor muscles, frequency 10 to 12 times a day, nocturia 4 to 5 times, abdominal muscle was 3/5, and then even the weakness was there in one of the extremity because of the sciatica, increased tone in the external anal sphincter, chronic constipation, and then long-term goals was completely to make her void completely. So we set the goal for the short-term goals and long-term goals to improve the quality of life. So Jogo, EMG, biofeedback, pelvic floor relaxation therapy, downward training, reverse Kegel, Thiel massage, trigger release technique, myofascial release, pain neuroscience education, bladder diary with habitual bladder retraining, and the education about the role of pelvic floor muscle in micturition, proper posture for normal voiding, pelvic hygiene, everything do's and don'ts, and home program, back rehab, a lifestyle modification were given for 3 months, once a week for 10 weeks. So our relaxation before starting was 9 to 10 millivolts again in different position, and recruitment was 10 to 15, slow and quick 10 to 13. And then we were able to analyze her graph week by week, how she was doing in different positions, and we were giving structured pelvic floor relaxation training. And also important thing is abdominal contraction with pelvic floor relaxation. There was some dysenergy also for her. It was mimicking DESD, that is her external sphincter dysynergia. So we were training her how to contract the abdominal muscles while relaxing the pelvic floor muscles. Abdominal contraction with pelvic floor relaxation, which facilitates normal voiding. So we were giving training, and before and after, in the Indian toilet position, in Western toilet position, both the position we were giving this training. And then we can see after 10 weeks of pelvic floor therapy, the relaxation, pelvic floor muscles were able to relax, and relaxation has improved, and also the recruitment also is improved. Able to relax the pelvic floor muscles in all the 3 positions, like crook lying, supine lying, and side lying. And also now she is able to recruit only when the muscles relax, they can contract better. So she is now able to do the quick contractions and slow contractions better. So outcome measures before and after Jogo, 8/10, the Cosian has come down to 3, FGPA come down from 30/45 to 14/45, O'Leary sat 26/36 to 12/36. Her frequency came down from 15 times to 10, and then 20 to 30 minutes of interval to 2 hours of interval. And then nocturia came down 4 to 5 times to 2 times. So initiation of urine 11 to 12 seconds to 6 to 8 seconds. Total time to urinate 50 to 80, 60 seconds to 30 seconds. So we were able to do the internal examination before and after. As you can see, the patient demonstrated measurable progress in pelvic floor muscle strength, endurance, neuromuscular control. So now after the therapy, the patient was able to empty bladder completely in one time without having double voiding. Initiation time also decreased for urination, and the pain while filling the bladder has decreased. And then there is a decreased frequency of urination from 15 times a day to 8 times a day, and nocturia also reduced from 4 to 2. So a prescription can be sent for the pelvic floor therapy. And so far, we have treated about 3,962 patients, as you can see. Urinary incontinence topped the list 1247, prolapse 372, voiding dysfunction 372, chronic constipation 1165. We also treated antenatal, postnatal, fecal incontinence patients, interstitial cystitis, and sexual dysfunction, vaginismus conditions, and all. So this is the testimonial of 72-year-old female spinster from Nagarkoil, had urinary incontinence for 36 years, from 5 diapers to 1 diaper within 3 months. This is a lady from Nepal, 22 years.
Dr. Uma, you're not clearly audible.
Married grade. Urinate 250 to 300 ml with good flow.
Hello, Aarti. Shobha here.
Yeah, good evening, ma'am.
Good evening. Aarti, the talk is going on now?
Yes, ma'am.
Yes, ma'am.
I'll
Yes,
not
ma'am.
interrupt.
Yes, ma'am. Ma'am is in her costumes.
Where is
Ma'am,
Shobha
Shobha
Gude?
ma'am.
She's in some attire.
I think they are all in a conference.
Which one?
MCCon. Looking very cute,
Bhopal
ma'am.
INCON.
That's why I excuse myself. Sorry, Vijay and Aarti. all
Which
of them.
conference you are in, Shobha madam?
IMSCon.
Oh, Bhopal.
Bhopal, madam.
Oh, yeah, have fun.
Good evening, Shubha ma'am.
Hi,
Hello, madam.
good
Hello,
evening.
Vijay. Hello.
And
Shubha ma'am looking very
All
pretty.
all the very best. I'll connect next time for sure. All the very best.
Thank you, ma'am, for joining.
uh, sorry for the interference, madam. Uma, madam, kindly continue.
Sure.
Shubha didn't go.
Ma'am, how many more slides? Can I?
No, I have finished my presentation. When can I was not audible?
No.
Ma'am, you were audible. Your presentation was excellent.
Yeah, it was
Actually,
audible.
we have visualized Uma madam doing all these procedures in Chengalpet, and with the supervised pelvic floor physiotherapy, our treatment for the patient with pelvic floor problems, both having a weak pelvic floor or a rigid pelvic floor, really gets known to the patient as well as to us, so that it is very clear for us to base the management based on this. Excellent talk, Dr. Uma ma'am. So any questions, I think, can be put in the chat box for Uma madam to answer. Thank you so much for the wonderful opportunity to the entire Karnataka team.
Thank you, Dr. Meena. It was wonderful having you in spite of being at a conference.
Thank you.
Dr. Kiran had one question. He just wanted to know are these published?
Yes, doctor.
Yes, sir. Uma madam's papers are published. We have gone through those papers. So they are all evidence based.
Okay.
Madam runs a clinic here in Chennai, Jogo Clinic. and we refer patients to her as well.
Fine. Thank you.
Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you for the wonderful opportunity.
Thank you, madam. Thank you, madam. Thank you,
you,
Dr.
Vijay.
Meena.
Thank you. Thank you.
It's quite a unique subject, and there are a lot of curiosity among the delegates. So if there are any questions, it is welcome. We can go to the next session.
Meena ma'am, I would
Yeah.
like to ask one question. So nowadays we have this Kegel's chair, Tesla chair. So what is your take on that? How do you feel it is? Have you used that?
Yeah. Yeah. So first, when we went to a US conference along with Professor Rajamaheshri madam, that is when I sat on the chair. They are helpful, but they are not a permanent cure. They can give multiple contractions, more than 10,000 contractions at the particular time. It will help for a shorter time, but it is not a permanent cure. The permanent thing is our own pelvic floor muscles, which has to be strengthened by us by doing the proper Kegels exercise for a weak floor and for a tightened floor.
In fact, we had a session once on Tesla
Dr.
chair, and
Uma
I
can
also added.
add some input.
Yeah.
Yes,
So
the chair is
Uma ma'am.
as Dr. Meena mentioned, so the brain has to be involved in the learning process and it has to be recruited. When you compare the normal muscle contractions, it has to contract and relax. The fatigue factor is there. We can't give tetanic type of contractions, right? So that's what happening here. And then the patient has to be participated. Here it's more of a passive. There is vigorous tetanic type of contractions using electromagnetic principle. So again, when the patient learns and performs and recruit the muscles, it will be long lasting, causing neuroplastic changes, and it will be permanent learning process. So it is always better than the passive. Any form of passive modalities. Those days we used to give electrical stimulation, using pen electrodes 30 years back. That was like temporarily contracting. The patient has to learn and then perform. But here in biofeedback, the patient is contracting and can see that in the audio visual in the form of graph. So the patient is able to learn and then trial and error learning. It's like learning the bike. We fall and we make mistakes and then we learn properly and then we will be mastering the technique. So even physiotherapists, doctors fail on the first day. When I give the lab sessions and training to the physiotherapists to become a certified pelvic floor therapist, they are also having weak pelvic floor muscles. They are not recruiting properly. Using the graph, they are learning and then they are becoming mastering in that. So the active participation learning is important.
So biofeedback is very important rather than just asking them to do the Kegels exercise.
Yeah. Thank you, ma'am.
Yeah, supervised pelvic floor therapy really helps. We can see Kavita ma'am has joined. Kavita ma'am.
We can see Kavita ma'am.
Kavita ma'am. Hello, Kavita ma'am. Can you unmute? I think madam is sitting in a conference.
Yeah.
Thank you. Thank you for the wonderful opportunity. Kavita ma'am, can you unmute? I think Kavita ma'am and Amita Jain. Amita Jain. Yeah, muted. Okay, bye.
Yeah, take care. Bye.
Thank you all. I think we are getting. So we will start with the second session. So for the second session, we have Dr. Indukala ma'am and Dr. Jyoti GS ma'am as the chairpersons. Can you please put the CV? So Dr. Indukala ma'am, she is Professor, Department of OBG, Saptagiri Institute of Medical Science. She is a former professor and unit chief, BMC, currently working as senior consultant, Malti Manipal Hospital, served as the coordinator, Karnataka State for PPIUCD program and member for PCPNDT Act, immediate past president of Karnataka State Chapter of Association Gynec-Oncologists of India. Her special interest teaching infertility and preventive gynec-oncology. Dr. Jyoti ma'am. Arun. Dr. Jyoti G.S. ma'am, she is professor and head of the department, MS Ramya Medical College, Bangalore. She is vice president BSOG from 21-22. She has Limca Award for Nutrition Advice in Pregnancy, member of Food, Drugs and Microsurgical Equipments and Gynec Oncology Committee of FOXY from 2018 to 2027. So she is lead assessor for the Manyata project on maternal and child health, lead resource person and expert for Parivartan project of contraception 2018 to 2020, TOT trainer for PPIUCD project of FOXY and FIGO, master trainer for the FOXY program. She has various national and state level publications, more than 50 publications. She has authored a book. She is life member of various professional bodies like FOXY, IMA, IMS, NARCHI, BPNL, ISSP, ISCCP, participated in the largest cervical screening camp in 2015, and it has been entered into the Guinness Book of World Records for doing maximum number of pap smears in a day. She is member and secretary of Safe Motherhood and member of Preventive Oncology Committee of Kasoga, 21 to 23, advisory committee member of Kasoga, Public Awareness Committee, investigator in various national and international clinical trials. Over to you, ma'am. Can one of the chairpersons kindly introduce our speaker for the next session, Dr. Kiran? Ma'am, unmute, ma'am. Indukala, ma'am, or Jyoti, ma'am?
Dr. Kiran Ashok is very well known to us, always helping us, like Vijay Kumar, for all our urogynecological conferences and cases. And he's from our own KIMS Hubli, and he's a renowned urogynecologist, and he has done various courses, fellowships, diplomas, and not only from India, also from abroad. And he's a consultant gynecologist at ESI Hospital, Pina, currently, and is a visiting consultant urogynecologist, so much sought after, for example, in Manipal Hospitals, Hebal and Millers Road, Bangalore. Over to you, sir, for a very fruitful discussion.
Thank you, ma'am.
On this
Thank you for
very
the
interesting topic on neuromodulation.
Thank you, ma'am. Okay. Good evening, everyone. Can I start? Vijay, sir?
Please start.
Please, sir.
Good evening. At the outset, I would like to thank Kasoga for inviting me to this webinar. Thank you, Dr. Durga Das sir, Vijay Kumar sir, and Aarti madam. So I'll start with my topic, neuromodulation in overactive bladder. And I'm almost sure that most of us have not heard the term neuromodulation. So before that, few slides, we'll start from basic and then we'll go to the actual topic. So what is an overactive bladder? So it's usually defined as urinary urgency accompanied by frequency and nocturia with or without urinary urgency incontinence. Most importantly, in the absence of UTI or other obvious pathology. So I think we all know about overactive bladder. And we know that various treatments like anticholinergic drugs, tolterodine, darifenacin, solifenacin, most of us are aware of it and most of us are using it. Now, what is refractory overactive bladder? So it is when the first line therapies like medications, behavioral modifications, and pelvic floor physiotherapy fail, we term it as refractory overactive bladder, which means it is refractory to regular therapies. Hello? Talk a little. Okay. So what options do we have in refractory overactive bladder? Either we can escalate the dose or change the combination. For example, if we are using darifenacin 7.5 mg, increase it to 15 mg per day, or you add mirabegron in combination with darifenacin. This can be tried. Second thing is, along with medication, we can add behavioral therapy like bladder training and lifestyle changes, which I think the previous speaker has already spoken up. And the third thing is treat mixed urinary incontinence. Many women with overactive bladder will also have some amount of stress incontinence. And in such cases, treating stress incontinence to some extent helps in overactive bladder symptoms. And then if there is any anterior vaginal prolapse like cystocele with increased residual urine, so correcting that will help in overactive bladder. So if all these things fail, we are left with two options. One is Botox injection into the bladder, and the last one option would be neuromodulation. So here I'll be talking or concentrating more on neuromodulation. So before going in for neuromodulation, how do we evaluate a refractory overactive bladder? So for a simple overactive bladder, we usually don't need urodynamic studies. But in cases of refractory overactive bladder, urodynamic studies, particularly filling cystometry and voiding cystometry, is a must. Cystoscopy is an adjunct. And most importantly, much more important than urodynamics, I mean, in my opinion, is using a bladder diary. So because this helps to quantify the effect of our therapy before and after, an objective quantification. So suppose if the patient is having a frequency of 10 to 15 times during daytime, so after starting therapy, what is her frequency? Like that, number of urgency symptoms or number of incontinence episodes we can compare with pre and post therapy regimes. So now, what is neuromodulation for overactive bladder? See, neuromodulation is a reversible and minimally invasive therapy. Basically, it is low voltage electrical stimulation to modulate sacral nerves or peripheral nerves. Unlike pelvic floor physiotherapy, here we are directly stimulating the nerves, not the pelvic floor muscles. Okay, like sacral nerves or tibial nerves, peripheral nerves like tibial nerve that control bladder and pelvic floor. It is something similar to a pacemaker. How we use a pacemaker for heart, here we can use a pacemaker for the bladder. So to understand what is neuromodulation, we need to have a little idea about basic neurophysiology of bladder function. So it's not a complex topic, but I'm trying to make it as simple as possible. See, cardiovascular and gastrointestinal system can to some extent function independent of nervous system. Even if in brain dead patients, heart can keep functioning and GI system can function. But bladder requires complete support of CNS to function normally, central nervous system to function normally. It needs both brain and spinal cord to function normally. Without that, it becomes, it doesn't function at all. So we'll start with peripheral nervous system in relation to lower urinary tract. As we know, there is a sacral parasympathetic flow, and there is thoracolumbar sympathetic outflow, and lastly, somatic pudendal innervations. So what does parasympathetic system do for bladder? Parasympathetic system is mainly involved in voiding. In other words, it helps in expelling urine by contracting detrusor and relaxing the urethra. So this it does by cholinergic stimulation of mainly M2 and M3 important stimulation of detrusor muscle and relaxes the urethra. It's like an acronym, P for peeing. So it helps in passing urine, parasympathetic pathway. So the next is thoracolumbar sympathetic pathway. What is the function of sympathetic system? Sympathetic system basically helps in storage of urine. So it travels through hypogastric nerves in front of the sacral promontory, and its main function is it inhibits detrusor by beta-3 adrenergic activity, and at the same time it contracts urethral sphincter. That way it helps in relaxation of the detrusor and closing of the sphincter, leading to storage of urine. So during storage, it is a sympathetic pathway that helps in urinary storage. And the third one is somatic efferent pathway, that is the motor neurons in the ventral horn of S2, S3, also known as Onuf's nucleus. So it travels through pudendal nerves, and then it causes contraction of the striated urethral sphincter. It can be a voluntary and it can also be involuntary contraction of the striated sphincter. So now bladder has two phases. Either it can be in storage phase or it can be in voiding phase. 99% of time, bladder is in the storage phase. For example, in a 24 hours time, bladder is in voiding phase only for, let us say, 5 to 6 minutes, right? Not more than 7 or 8 minutes. But the rest of the time, it is always in storage phase. Storage phase is almost entirely a spinal cord function. It doesn't usually require brain. That's mainly the the spinal cord function, it doesn't require brain and pons. Whereas voiding phase is controlled by higher brain centers like pontine micturition center and midbrain, as well as the parietal and frontal cortex. So here I will concentrate more on storage phase, because overactive bladder is mainly a disorder of the storage phase. So bladder is unable to store urine due to leak of urine for so many reasons. So voiding phase is actually very interesting, because we need to talk on higher brain centers, but due to lack of time, I will not go into the details of voiding phase, how voiding is controlled by brain centers. So let us concentrate more on storage phase and how it is maintained. So as we know, bladder is one organ which can distend from 0 to up to, we have seen a woman having 1000 ml bladder capacities. So what happens is, as the urine comes into the bladder gradually distends. Normally what we expect, whenever a visceral organ is distending, there should be an increase in luminal pressure. But that doesn't happen in bladder, because as the bladder is getting filled, there is a relaxation of the detrusor muscle. So it tries to accommodate more urine. As the bladder gets filled, the bladder is relaxing, detrusor is relaxing at the same time. That way it can easily accommodate more urine without substantial rise in intravesical pressure. So this is important. Even at 500 ml filling, there might not be more than 15 centimeters of water in bladder pressure. That is the ability of detrusor to relax. How this relaxation happens? So as the bladder is gradually filled, there will be a low level afferent firing from the bladder. The sensations, the stretching of the detrusor muscle is carried through afferent nerves into the spinal cord. See, even storage is not a passive phenomenon. Storage is actually a reflex. It's a spinal reflex. So as the bladder gradually distends, afferent fibers carry the sensation of distension into the spinal cord. At the same time, spinal cord sends sympathetic innervation or sympathetic activation to bladder to cause detrusor relaxation and urethral sphincter contraction. So also spinal cord, this reflex arc also sends signals to somatic pudendal stimulation, leading to contraction of the external urethral sphincter. So basically it is a reflex relaxation during storage phase, and for that sympathetic innervation is very important. Now, see, usually these sensations of bladder filling, as the bladder gradually fills, these sensations are traveled by myelinated A delta fibers. Basically, don't think too much about A delta fibers. They will just afferent neurons. They travel to spinal cord and they convey sensation of normal distension of bladder. Okay. Then there is another set of afferent nerves which carry abnormal sensations from bladder into the spinal cord and to the higher centers. These are known as unmyelinated C fibers, and they're large fibers. They're usually quiescent. They're usually not active. But whenever there is an infection or inflammation or any neurological problem in the bladder, C fibers are stimulated, and these fibers will carry the sensation to spinal cord. And instead of relaxing the bladder, any afferent signals in C fibers will tend to cause voiding. It tries to contract bladder. See, the A delta fibers will cause relaxation of the bladder due to bladder distension, whereas C fiber afferent activity will cause bladder voiding, because it's basically a pathological phenomenon. So normally, as I said, C fibers are quiescent and they are unresponsive to bladder distension. But if there is any pathological problem, these fibers, they evolve to respond to bladder distension and activate voiding reflexes. So this emergence of new reflex circuits mediated by C fiber afferents play an important role in the pathogenesis of bladder hyperactivity, leading to overactive bladder. So the neuromodulation is thought to block C fiber activities and hence inhibit abnormal voiding reflexes. We want storage, right? Not voiding. So the same thing. So what does neuromodulation do? Neuromodulation is we are directly stimulating the nerves using electrical currents and using electrical stimulators, and they inhibit spinal neurons involved in micturition reflex. In particular, they inhibit the afferent arc of the spinal reflex. Particularly, they inhibit C fiber afferent transmission. So by inhibiting bladder afferent activities through its action on somatic afferent pathways, mainly C fibers, they block abnormal sensory input to bladder, spinal cord and brain. So neuromodulation may also block interneuronal transmission of bladder sensory input. there is another function where it directly inhibits the post-preganglionic neurons of the bladder efferent pathways. That way it prevents bladder contraction. It can, so this is bladder, spinal cord. So there is, it also, first is it inhibits the afferent pathway, and secondly, it also, there is some effect on the efferent pathways where signals from spinal cord may not reach the urinary bladder to contract. So that is how neuromodulation works. So where do we use neuromodulation? It's mainly used in overactive bladder, mainly refractory overactive bladder, and it can also be used in non-obstructive urinary retention. So more commonly, we see this condition in obstetrics and gynecology in patients with postpartum urinary retention, and following a radical hysterectomy, patient can go for urinary retention. In such conditions, neuromodulation definitely helps. Other indication is fecal incontinence. So neuromodulation has been tried for fecal incontinence with very good results. So we'll come to the results section later. So there are actually two types of neuromodulation. One is sacral neuromodulation, where we directly stimulate the sacral nerves, and the second thing is peripheral neuromodulation. We can stimulate peripheral nerves like posterior tibial nerve and pudendal nerve. We'll come to it one by one. What is sacral neuromodulation? As you can see in the picture, so we insert a tined lead into the S3 foramina under fluoroscopic guidance. Okay, and deliver electrical current to the tined needle. Thereby, it activates the dorsal nerves. You know, the ventral nerves are involved more in motor responses. The dorsal nerves are involved more in sensory responses. So our aim is to modulate the sensory responses or abnormal sensations from the bladder. So that way, this needle is inserted into the S3 foramina and stimulates the sacral nerves. So basically, sacral neuromodulation, I would say, is a very expensive thing, actually. First of all, let me make it clear, because sacral neuromodulation will cost not less than 12 lakhs. So it consists of two stages. Stage one is a trial of a tined lead for external stimulation. If the patient gets benefited in the first trial, patient can go for a permanent insertion of a subcutaneous implantable pulse generator, which is something like a pacemaker, into the buttocks. So what we do is, initially tined under fluoroscopic guidance, the sacral foramina are marked, and then under fluoroscopic guidance, a tined lead is inserted. You can see this is the sacrum. You can see the radio opaque lead, electrical, it's a connection. So it will be something like this, like fishbone technique, so that it doesn't come out easily. So under fluoroscopic guidance, a tined lead is inserted into the sacral foramina. And once it is inserted, you deliver a small amount of electrical current and look for the appropriate appropriate response. How do we know whether it is correctly in the S3 or not? So for that, when the electric current is applied, there will be a dorsiflexion of great toe, or sometimes even fanning off of the toes also. And second thing is, there will be Bellows contraction of the perineal area, something like it comes out and goes inside. So this is also known as Bellows reflex, where the perineal body is suddenly drawn inside and comes out. So when these two signs appear, we are sure that the lead is placed exactly in the S3 foramina. So once it is done, the patient wears an external pulse generator. We have not yet implanted the pacemaker. External pulse generator for approximately 2 weeks while recording his or her symptoms in a bladder diary. As I said, bladder diary is very important investigation before neuromodulation. So after 2 weeks, if there is greater than 50% improvement in symptoms, we can advise the patient to go for second stage of the procedure, that is implantation of permanent pacemaker or the implantable pulse generator. So you can see how it is. Actually, the lead is here into the S3 foramina, and there will be a percutaneous wire, and actually the implant generator is placed on the contralateral buttock. It's usually done on one side, not both the foramina. We don't do it on both the sides, usually done in one side. And a small pocket of subcutaneous pocket is created, and inside that pocket, this implantable pulse generator is inserted. Usually it is done onto the contralateral side, so that there is no interference. So the success rate, and then it will work for 5 to almost like 10 years. And sometimes you may need to change the implantable pulse generator also. But you can see the efficacy of sacral neuromodulation in a prospective multi-center randomized control study. The number of urgency incontinence episodes decreased from 9.6 to 4.7, almost more than 50% improvement. And that improvement persists for up to 5 years. So in this study, the clinical success rate is around 58% in number of leaks per day, 68% in number of heavy leaks per day, and 61% reduction in the number of pads per day. Other studies have shown long-term success rates up to 80 to 84%. But as you can see, putting a needle into the sacral foramen is not an easy thing. So it can lead to some complications. Sometimes the lead can migrate, so without any improvement in efficacy. There definitely will be pain at the implant or lead side, but it is usually temporary. There can be superficial wound infection. Sometimes implant dysfunction or infection can happen, and it can dysfunction also. Seroma can develop at the pacemaker site. And sometimes even when the patient is sitting, suddenly she might experience a sensation of electric shock in the buttocks and legs, and skin erosion at the site of implantable pulse generator. So there are some of the contraindications, but nowadays, see, initially MRI was a contraindication, but nowadays they're developing systems which in which once implanted MRI can be used. So urinary retention secondary to anatomic obstruction. Obviously, in such cases, we don't do sacral neuromodulation. And patients who have not demonstrated appropriate response to test stimulation. As I said, for 2 weeks, we do a test simulation. If there is no response, we do not proceed with permanent implant. And patients who are unable to operate the neurostimulator. So this is a bit invasive. Sacral neuromodulation is a bit invasive. So in order to overcome these problems, another technique was developed, which is known as posterior tibial nerve stimulation. We also term it as percutaneous tibial nerve stimulation. Percutaneous means we insert a needle through the skin to touch the tibial nerve and then stimulate the nerve. So PTNS is a method of peripheral neuromodulation. It was approved by FDA as early as 2000 and 2000 for urgency incontinence in 2000 and overactive bladder in 2010. So PTNS also works by modulating afferent impulses from S2 to S4. So basically what is done is once the patient comes for PTNS, percutaneous tibial nerve stimulation, it is done in an outpatient or clinic procedure. So it's a very simple technique. We use a needle, a 30 to 34 gauge needle. You know how thin it can be. Spinal needles 27 is quite thin, but these are much thinner than that. If it is not available, we can use acupuncture needles. So identify the medial malleolus 2 to 3 inches above the medial malleolus, just behind the shin or the tibia. So insert the needle. Continue inserting the needle until it touches the posterior tibial nerve. So how do we know it is touching the tibial nerve? The moment it touches, the patient will experience dorsiflexion of the toe as well as fanning of the toes, and sometimes even the tingling sensation. So once that is confirmed, that means the needle is in proper position and it is touching the nerve. Once this is done, then start applying, connect it to a electrical stimulator, Eurostim this is. So connect it to the generator and then continuously apply somewhere between 15 millivolts of electric current for about half an hour. So each session lasts half an hour. So usually we do it once or twice a week and for approximately 12 weeks. So within that 12 weeks, we record the patient's symptoms. If there is improvement, fine. Sometimes I have seen patients taking this device, they buy this device and they do it at home also. Initially, it is usually done by a doctor with themselves, but later on we can teach the patient to do it for themselves. It's mainly done for overactive bladder, and most commonly it is done for neurogenic bladders, where it has an important role. So you can see multiple studies. In fact, comparing it to tolterodine oral drugs, you don't have to take orally. When you're doing PTNS, there is no need for anticholinergic medication. But on comparison, you can see that PTNS is as good as better than tolterodine in improving overactive bladder symptoms. So and the last one is pudendal nerve stimulation. This is not an easy thing, unlike PTNS, which can be done in office settings. Here, what they do is they put a radio frequency generator at the level of ischial spine, touching the pudendal nerve. You can see under X-ray guidance, and that will continue to stimulate pudendal nerve, so leading to neuromodulation. So this is not commonly available, and it's also not an easy thing to do and insert. So I think out of this, PTNS is something workable. So what we do is in refractory overactive bladder, in my practice, I try botulinum first. If it doesn't work, we send it for nerve stimulation. So that is about neuromodulation. So this is a picture where it's like mapping how the spinal cord is related to caudal structures. The same structures that innervate bladder, urethra, and pelvic floor and rectum, they also innervate the foot. So this is one of the principles of peripheral neuromodulation. Thank you very much for your kind attention. Any questions?
Thank you so much, sir. That was a very wonderful lecture. You nicely navigated from the basics to the physiology to the latest therapy of neuromodulation. One thing I wanted to ask you, sir. You
Yes,
said
ma'am.
postpartum urinary retention.
Yes, ma'am.
Normally, postpartum urinary retention I have seen when we put forceps,
Yes, ma'am.
especially forceps or instrumental delivery, then we recatheterize within 24 to 48 hours, they become all right. But what are you keep telling us when you say postpartum urinary obstruction cases
Many
needing
times,
neuromodulation?
so if the patient recovers within 24 hours, it's well and good, ma'am. But we have seen many times they need catheterization for prolonged periods. Even after 2 or 3 weeks, they still have significant residual urine. So in such cases, we can start neuromodulation earlier so that she need not have to be on either intermittent catheterization or maybe continuous catheterization.
You mean in instrumental deliveries, following instrumental deliveries?
Not necessary, madam. Postmortem retention we have seen even after normal deliveries also sometimes it has
Yes,
happened.
correct.
Difficult
Especially
deliveries, maybe tardy.
no, not need not have to be difficult deliveries, Jyoti. Even in a little prolonged delivery. So what happens in the bladder becomes like a bag and toneless, and it is unnoticed, especially when the deliveries are conducted in the periphery by the nurses and yes. So I've seen so many the women coming with
EMC especially.
yes, with this condition, and it's really difficult to treat.
Normally we can recatheterize, madam, 24, 48, 72 hours and they become
No,
all
it
right.
won't. It won't. No, it will
well
not.
and good.
Yeah. No, I mean, it is unnoticed and it becomes
Nice to
chronic.
have one more backup technique with
Yes.
refractory cases.
Yeah. And Dr. Kiran, I want to tell you that this overactive bladder in women is a very, very common problem. But but I keep telling my students saying that our Indian attire, the 6-yard sari and the 9-yard sari, we're able, I mean, women are able to hide this problem and they don't come to the hospital. Yeah, that is the problem, you know. So, but they just endure this and die with it. So, I mean, it's a good thing that some latest technologies have come and they're able to this thing.
One more thing is we can observe that Indians wear toe rings.
Yeah.
Because wearing the ring, definitely it's the kind of neuromodulation. It stimulates tibial nerves.
Oh,
okay.
Directly connected to S3, S2, S3, S4.
Very nice, sir.
There is a link, ma'am. That
I really enjoyed your talk, doctor. As a physiotherapist, we use pain neuroscience and TENS.
Yes, ma'am.
To modify the nociceptive fibers, you were telling about C fibers, nociceptive fibers. Use the same gate control theory in pain control management.
Okay.
In overactive bladder, we also use the TENS in the medial tibial, above the medial malleolus with the surface electrode.
That is transcutaneous electrical stimulation.
Yes,
we were talking about percutaneous, you are talking about transcutaneous.
Yes, transcutaneous, TTNS.
Yes, ma'am.
I really enjoyed your talk. Each and everything was explained so well.
Very lucid.
Thank you, ma'am.
Dr. Kiran.
Yes, sir.
It was a fantastic talk,
Thank
as
you.
usual. I just wanted to know this PTNS, how frequently it has to be given and for what duration and how much it costs for the patient each session.
Sir, PTNS is usually started with twice a week session for 12 weeks, sir, totally.
Okay.
Most of we stop the treatment and observe for about some days, sometimes up to 1 year, patients will get benefit. Sometimes they come back again with symptoms after 1 year. In such cases, we repeat it. Almost like Botox, sir. Botox also, once we inject Botox, patient will be okay for 1 to 1.5 years. Again, they need another dose. So this also is similar, sir, actually.
So reinforcement is required.
Reinforce sometimes.
Sir, any
What is the
particular
cost of the treatment?
Unfortunately, in India, we are having, because I did this work in Italy, ma'am. So in India, I tried to get the percutaneous nerve stimulator. I couldn't get it. But we have transcutaneous, as the madam told. We can put a patch just above the medial malleolus posterior to tibia, and then we can do transcutaneous stimulation. In fact, it was being promoted by Dr. Vineet Mishra, urogynecologist in Ahmedabad. So, but I have advised many patients to get it from United States, Eurostim. It is the Eurostim. It costs about like $800 to $1,000, and they can use it at their home if they are okay with it, affordable. They can do it by themselves. We can teach them, and they can do it by themselves.
Oh, good. Okay.
Nice.
What about this latest? They're talking of this, the vaginal rejuvenation and PRP and things like that. Will it help?
Ma'am, regarding vaginal rejuvenation using lasers, the current data shows only short-term improvement, and that too, like the improvement doesn't persist beyond 6 months. That's what they're telling. So, as of now, Cochrane doesn't recommend it as a long-term therapy for stress incontinence or urgency incontinence.
Okay. Okay.
Sir, any particular contraindications for PTNS, sir?
PTNS, no, ma'am. Nothing much. There are almost no. It is almost like an extended version of physiotherapy. It's the nerve stimulation. Physiotherapists do it in a transcutaneous way without puncturing the skin. So we just put a needle through the skin and so that it touches the nerve. That's all.
Excellent talk, sir.
Thank you.
Nice.
It was lovely listening to you.
Yes.
And a lot of
went
things
through
we have learned today.
revision of my physiology of urogynecal bladder.
Yeah.
Really.
So
Thank you.
I would like to thank one and all. And Vijay sir, should we conclude?
Yeah, sure.
Yeah.
If there are no other questions, I just thank all my teachers, Indukala madam, Jyoti madam, and I also thank our speakers. Today's evening, the scientific program was very useful for all of us. It's very informative. We look forward for such the scientific sessions. So thank you all.
Thank you, sir.
Thank you. Thank you.
Thank you, Arti. Thank you, everyone.
Thank you, doctor.
Thank you so much. Thank you, Vijay
Thank
sir.
you,
Thank you,
Vijay,
Kiran sir.
Aarti, Indu madam.
Indu
Hello.
ma'am.
Thank
Jyoti
you.
ma'am. Yeah.
Thank you all.
Thank you so much. It was wonderful.
Wonderful.
Good
Thank you.
night.
Good night. Good night.